Sure. So some of the advantages and some of the limitations of the newer or the direct-acting oral anticoagulants. The advantage is we do not have to monitor them. We can give it to a patient. Some of the direct-acting are once a day, some of the direct-acting are twice a day, but we do not have to monitor it. So it's the anticoagulant effect is predictable. So that's one advantage. Other advantage, it does not have any food interactions or food complications we have to worry about. They do have drug-drug interactions, so that's something we have to monitor. Hopefully the prescribing clinician is aware of those drug-drug interactions, such as the glycoprotein or CYP3A4 inhibitors or inducers are direct drug-drug interactions. One of the issues we've seen is because of the short half-life of the new direct-acting oral anticoagulants, if a patient misses or is not adherent to their therapies, they become not anticoagulated within 24 hours of missing a dose. So it puts the patient at risk for a thromboembolic event, such as a stroke, if we have the patient on it for AFib, stroke prevention. So from an advantage or a disadvantage from a managed care situation for the direct-acting oral anticoagulants. An advantage is we have another tool in our toolbox for patients that have known atrial fibrillation or known patient that has a history of VTE that we want to continue to anticoagulate, but the patient did not want to come in or adhere to the monitoring process with warfarin. Now we have a choice to anticoagulate these patients without the burdensome issue, as some patients see the monitoring of warfarin as a burdensome issue. So it's another tool in the toolbox for those patients. But on the other end, the direct-acting oral anticoagulants, because we're not monitoring those, adherence to chronic therapies cannot be assessed. So, or it can be assessed, but it's a little more difficult to assess. So for instance, if we have a patient that we have on a direct-acting oral anticoagulant, they come into our emergency room with a stroke. How do we assess if it's failure of drug or failure of patient? There are some parameters that we can draw. They're not as finite, or they're not as conclusive as it would be if a patient was on warfarin and they came in with an acute event with warfarin. I can draw the level, I can draw the clotting time, draw an INR, but with the direct-acting oral anticoagulants, we can draw a drug level, but only within so many hours of the dose. And to assess compliance and assess whether it's failure of patient or failure of drug is actually a limitation of the direct-acting. So do or does age and comorbid conditions affect decision-making of whether to anticoagulate a patient and or what agent we use to anticoagulate these patients? And that is a very difficult question, and I'll answer it in a couple different ways. So first is as we increase in age and we have an atrial fibrillation patient, the risk of stroke goes up. All right, so the patient's risk for stroke will increase. But also as age increases, the risk for bleed increases. So we have two sides of the coin we're trying to balance. With patients that are on warfarin and they bleed, currently we do not have an antidote, but we have methods to stop or prevent the bleed from becoming worse. With the direct-acting oral anticoagulants, today, as I sit here, we have no method or an antidote for the direct-acting oral anticoagulant. So on the bleed side, we have a concern. So when we're choosing the anticoagulant, we have to weigh and look at the patient sitting in front of us and weigh the risk for thrombus and bleed because of profession, because of maybe their gait, or they're at high fall risk. So what would we choose based off of that for then if we would have a complication for the patient? We also have to look at cost. So we think of this as if I'm a patient that is in a managed care organization, so part of an accountable care organization, and I'm also not only the caregiver, but I'm the payer. When I look at the cost, the direct cost of care for a direct-acting oral anticoagulant compared to the cost of care for warfarin, the cost of care for warfarin is a lot cheaper to get the same outcome because we're touching the patient in multiple ways. So we have to look at it. And if in another instance, if I'm fee for service, so if I'm not insuring the patient, but I'm the caregiver taking care of the patient, it would behoove me to move to the direct-acting oral anticoagulants, as I'm not getting reimbursed for that management of warfarin. So it depends on the organization and essentially the type of organization and the way the patient's insured. So sorry to say, but the reimbursement and also the total cost of care based off of the practice style is brought into the decision.